Okay, so we're back. My name is Adure Waba. I use the pronouns she, her, hers, and I'm an able-bodied cisgender female. I'm Nigerian American and was born and raised in Maryland, closer to Baltimore. I'm wearing a gray sweater today, and I have a white, sunny background behind me. I'm a third-year medical student at the University of Michigan. Today, I'm honored to introduce Dr. Uche Blackstock, our final keynote speaker for the conference. She's one of the leading voices on speaking about bias and racism in healthcare, and she earned both her undergraduate and medical school degrees from Harvard University. She's the founder and CEO of Advancing Health Equity, which partners with healthcare organizations to eradicate racial health inequities through keynote talks, trainings, and consulting services. In 2019, she was recognized as one of the 10 diversity and inclusion trailblazers you need to get familiar with. And in 2020, she was one of 31 inaugural leaders awarded an unrestricted grant for her advocacy work from the Black Voices for Black Justice Fund. She's a former associate professor in the Department of Emergency Medicine and the former faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. She left her faculty position at NYU in December 2019 after almost 10 years to focus on advancing health equity. Since 2020, since June 2020, she's been a Yahoo News medical contributor and appears regularly on cable and broadcast news programming to amplify the message around racial health inequities. So without further ado, here is Dr. Uche Blackstock to close out our conference today.
Oh, thank you for that intro, Adure. So hi, everyone. I'm Dr. Uche Blackstock. I use she, her, and hers pronouns, and I'm an able-bodied cisgendered female. I'm Black American. I was born in Brooklyn, New York, and I'm wearing a blue and green dress and green earrings, and I'm sitting in a sunny room with artwork on the back. And I'm also founder and CEO of Advancing Health Equity. Thank you so much for having me. I'm going to just share my screen with you. And so I just want to give everyone a heads up that I like to just engage with you all in the chat. I know virtual talks are very interesting. I wish I was in person with you all, but I may ask for your just feedback in the chat, and just let me know if the chat box is ever making, like, sometimes it makes a black box on the screen. So just give me a heads up for that. I just usually start my talks by telling people a little bit about myself. So this is my mother. She's the original Dr. Blackstock. This is her holding my twin sister, Oni, and me. She was a second-year resident at Harlem Hospital at the time. So that's why she kind of looks both happy and tired. And this was at our christening. But my mom grew up about 15 minutes from where I am right now, here in Brooklyn, New York. Very different circumstances that I did. She's a single mom, born to a single mother. She's raised on public assistance. First person in her family to go to college, and she went to Brooklyn College, and she was fortunate enough there to have a professor, chemistry professor, who saw the potential in her and encouraged her to apply to medical school. And so she applied to medical school and got into every single medical school. And she ended up matriculating at Harvard Medical School. And afterwards, she came back to Brooklyn, and she trained here, and she cared for her neighbors, mentored many medical students and faculty, and just really was a definition of giving back. This is Oni and me with our dad at our medical school graduation. Unfortunately, our mom couldn't be there because she passed away after our sophomore year in college from acute myelogenous leukemia. But both my sister and me, in the work that we do, we hope to honor her legacy always. But our dad is an immigrant from Jamaica. He worked probably about 10 different odd jobs before he ended up in college. He came to the States when he was 18 years old, and he and our mom just worked incredibly hard to give us lives that had more opportunities than they did. So we just are incredibly indebted to them. And then some of you also know that I was in academic medicine, as Dory mentioned, for about 10 years. And it was my own experiences in academic medicine and really recognizing that, these institutions that are supposed to be, training us and supporting faculty are not doing that. And they often are very, have environments that are inequitable, and that inequity often trickles down to the care that is provided to patients. And so I started advancing health equity about a year before I even left, because I knew that I wanted to work more so externally with these institutions to address issues around racism in medicine. So these are the objectives. I only have 30 minutes to speak with you all, so I'm going to try to not go too quickly, but I have a lot of content. So these are the objectives: how systemic racism produces racial health inequities. We'll talk about the 4 I's of oppression framework, and then hopefully end with some practical strategies. And so, a lot of what motivates me to do the work that I do is, these statistics that we have, that are really, despite advances in healthcare innovation and technology over the last decades, we actually have had inequities even worsen during that time. And so these are just some of the current statistics, which I know most of you are already aware of. But even thinking about the recent CDC data showing from January to June of last year, Black men who already had the shortest life expectancy of any racial demographic group, their life expectancy dropped by 3 years from the COVID pandemic. And so I'd like to use this slide just to give some context for some of the inequities that we're seeing today. So if you look towards the left, about 15 years before the end of slavery, many babies did not live to their first birthday. The infant mortality rate overall was quite high. However, Black babies still were more likely to die within their first year of life than white babies. But over time, with improvements in sanitation, nutrition, living conditions, overall rates improved. However, in the 1960s, the US was still last among all industrialized countries with the highest infant mortality rate. And then fast forward to current day, if you look at the numbers in the upper right corner, while the overall infant mortality rates have improved significantly, we actually there's a larger Black-white disparity today, with Black babies more than twice as likely to die in their first year of life than there was in 1850, 15 years before the end of slavery. And so while significant work has been done, we still have a lot more work to do. And I know some of you are familiar with this study that Dr. Hardiman out of Minnesota and her team published, but looking at how racial concordance, even in the in neonatologists and pediatricians, actually influences infant mortality rate. And I know many of you know about the maternal mortality rates, and I actually would recommend reading this article. Even it's not in a journal, but it's a really well written article by Linda Villarosa about the Black maternal mortality crisis. It was in New York Times Magazine in April of 2018, but really puts a really personal twist on it. And she follows several Black mothers that have experienced pregnancy complications. But what's interesting is that, we know that the data, Black women are 3 to 4 times more likely to die of pregnancy-related complications than white women. And here in New York City, it's as high as 12 times. So Black women are 12 times more likely to die around pregnancy. And even myself, as a Black woman with a medical degree, I have a higher likelihood of dying than a white woman who has not finished high school. And so that's where we are. And we know even these 2 women talked about their own experiences. So does anyone know, and you can just drop it in the chat, what did these 2 women talk about during and after their pregnancies that they experienced? And so I put them on the screen because often people will say health inequities are a result of socioeconomic differences in status. And the fact is that they're not, is because we still see these inequity gaps across socioeconomic status and across income. So yeah, right, Serena Williams had a history of a pulmonary embolism, and after her pregnancy complained of shortness of breath and ended up having another PE, but she talks about feeling like her concerns were not heard. And then also Beyonce talks about her own situation. I think she had some signs of preeclampsia that she shared with her team, and also feeling like she wasn't being listened to. So, oh, hi Abubakar. Okay, so Abubakar says Serena Williams had DVT, that she had to self-advocate to get properly diagnosed and treated, right? And so this is a woman of affluence, of means. She's a professional athlete. She knows her body, but still, as Abike said, not being heard. Anna says knowing that they were sick and not being listened to by numerous health professionals. So exactly. And so just to ask everyone this question, why do we see these racial health inequities despite status? So someone mentioned, Lisa mentioned not being listened to. What are some other reasons why these health inequities still persist? So Patricia says stigma and stereotype. David says the weathering of racism. Jenny says racism, white supremacy. So, right, so not much diversity in medicine, right? So we know that racial concordance matters. We know that there's provider bias. We know that there is the weathering effect, like the physiologic aging of the bodies of people of color in this country due to everyday racism. And then Lisa makes the appropriate comment that this is not just a medicine issue, it's a nursing issue, it's an overall, it's a healthcare issue. And then Sarita mentions that this belief that Black women have a higher pain threshold. And there's so much literature in the pain literature that supports this, that the pain of Black people and other people of color is often underappreciated and undervalued in the healthcare setting. And so Jonathan says both conscious and unconscious bias. And I just want to make a point of saying that, we often talk about unconscious bias as if it's this benign phenomenon, but it's not. It's just as harmful as explicit bias, as explicit racism. So thank you for those comments. And so I'm not going to spend too much time on this slide, but I know that I just think it's important that often we conflate equality and equity. And the difference with equity is that we are acknowledging that people are starting out with different advantages and disadvantages, differential access to resources, power, opportunities, and experiences. And so equality is essentially giving everyone the same thing without recognizing the barriers and disadvantages that people are starting out with, whereas equity is giving each person what they need to reach their highest potential. And so I wanted to share this slide with you all, and I don't know how much you're discussing structural competency at your respective institutions, but it's this idea, this shift away from cultural competency, which essentially sometimes boils down to a list of stereotypes about different non-white racial and ethnic groups. So it's this idea that we need to think further upstream, so towards the left, than the social determinants of health. So we know the social determinants of health are incredibly important in terms of influencing health outcomes, but there are social structures that dictate social and economic policies, the fact that we live in a capitalist system, the fact that there is systemic racism that actually shapes and influences the social determinants of health. And so if we're thinking about, what do we need to do to address health inequities, it's not just about addressing social determinants of health. We need to think further upstream. And so this is another kind of like a money slide that I want you all to just take home with you. And I feel like the whole conversation about that JAMA podcast, I think is almost exemplified in this slide, that, when people think about, when a lot of, often people think about racism, they think about this interpersonal racism, because that's the racism that you can see, that's more overt. Hate crimes, microaggressions, calling someone a racist slur. But what is the foundation of racism is systemic racism. It's what is more covert, what is more difficult to see, what is under the water, and what really sustains racism. And so thinking about practices and policies that reinforce negative stereotypes in the media, mass incarceration, political representation, the policies that have led to residential segregation, like mortgage redlining. And that is what we need to really be focusing on and addressing if we want to address health outcomes. And so I have some history lessons for you all. Who's this person on the right side of the screen? I want you to drop that in the chat for me. So thank you. Oh yes, it's FDR. And FDR is well known for developing the New Deal. What do you know about the New Deal? What was the whole point of it? I want to make sure I'm staying on schedule for you guys. So Maria says social welfare. So yeah, so does anyone remember what the point of it? It was to help, right. So Barbara says, right, help Americans, pull Americans out of the Great Depression, exactly. Americans, businesses. And so the New Deal is known for the creation of the federal, one of the reasons, the Federal Housing Association. And the FHA is actually responsible for the creation of the suburbs. We'll get to redlining, Thomas, but we're gonna first focus on the suburbs. And so there's a reason why suburbs were mostly white to begin with. The reason why these mass subdivisions were mostly white was because as part of the New Deal, there were clauses in the deeds of these subdivisions that prohibited sale to Black Americans and other Americans of color. You could only sell the property to a white person or white family. And additionally, there were clauses in the deeds that prevented resale. So even if a white family purchased a home in the suburb, they can only sell it to another white family. They could not sell it to a person of color. So this is just one aspect of the New Deal I want you all to understand, and that had led to the suburbs being mostly white. Now, Thomas mentioned mortgage redlining, which I know a lot of folks know about. And I wonder if people can just drop in the chat, what do you know about redlining? While you're doing that, I'll just let you know there is a map on the right side of the screen from Portland from the 1930s. And Richmond University has a really wonderful supply of redlining maps from all across the country. You should just go there and take a look at it. But essentially, I was hoping people would drop in the chat what redlining is. I don't want to have to give you the answer. I know people know. So the New Deal also led to the creation of the Homeowners Loan Corporation. And yes, Maria says people went around block for block and gave these blocks colors. Yeah, so there are these essentially based on who lived in the neighborhood, and really not much else, these neighborhoods were graded. And so essentially if the neighborhood was mostly white professional, that neighborhood got an A grade. And what that meant was if you lived in that neighborhood, simply because you lived in that neighborhood, you are more likely to be able to qualify for a federally backed mortgage and mortgage insurance. Conversely, if you lived in a redlined neighborhood, so the ones that are lined in red, you were, just by virtue of living in that neighborhood, unlikely to be able to qualify for a federally backed mortgage. And so I'm going to go more into some details. I'm going to blow this up a little bit. This is an actual redlining document, and people are putting a lot of great comments in the chat. So this is from a neighborhood in Portland called Gainsborough. And if you notice, it says it's asking for the occupation. This is mostly business and professional men, white collar, foreign-born families, none. And this is a federal document. They're using these very pejorative terms, subversive, for foreign-born families. They ask about, are there any Negro people living there? And then item E, is there any infiltration? So infiltration, again, really pejorative terms talking about whether or not there's infiltration of racial and ethnic minorities in this neighborhood. So this neighborhood got an A-. So if you lived in this neighborhood, it was like a green area, you were more likely to be able to qualify for a federally backed mortgage just because you lived in this neighborhood. This is another neighborhood in Portland called Lower Albina. And it was mostly made of service workers, laborers, artisans. The income was slightly less, mostly 40% foreign-born families. It says Southern European and Orientals, Negro many, and infiltration, subversive races continuing. And if you look in the clarifying remarks, it says the area constitutes Portland's melting pot and is the nearest approach to a slum district in the city. 3/4 of the Negro population of the city reside here. In addition, there are some 300 Orientals, 1,000 Southern Europeans, and Russians. And so this neighborhood got a D-. So if you lived in this neighborhood, just because you lived in the neighborhood, not because of anything else, you were less likely to be able to qualify for a mortgage and to buy property. So I have one more policy I want to share with you, the GI Bill. What do you all know about the GI Bill? What was the whole point of the GI Bill? and just drop that in the chat. So yes, Anisha says, so yes, most people think about the GI Bill as assistance, offering financial assistance, educational assistance to returning, yes, World War II veterans, and help them to pay to go to college. However, most people don't know, and thank you, Jenny, that it's actually, there's a housing provision of it. And the housing provision helped to give mortgages to these returning World War II veterans so they could buy homes. However, as Nisha points out, banks would not give Black veterans mortgages to live in Black neighborhoods. They said it was too risky. And if you recall, at the time, in the 1940s, Black people were not permitted to live in white neighborhoods. So they could not get a mortgage to live in a white neighborhood or a Black neighborhood. So they were not actually able to take advantage of the housing provision of the GI Bill. So Thomas says returning service people could get assistance with college costs. Yes, so definitely that, but the housing provision, everyone was not able to take advantage of that. And these policies I just went over with you, and these are just some of the policies. That wasn't even an exhaustive list, but has led to the racial wealth gap that we see today, where Black and Latino families essentially make or have a fraction of the wealth of white families. And it's not because Black and Latino families did not work hard. It's because there are federal policies that advantage white families and enabled them to purchase homes. And what's one way that we accumulate wealth in this country? The main way is through home ownership, right? And so if you're blocking people from buying property, then they cannot establish wealth, right? And they cannot pass it on from generation to generation. And so that's why we have maps like this one from St. Louis, where literally just blocks apart. And I know probably so many of you that are listening in have the same experience, like where you grew up, just like blocks away, the neighborhood changes, right? Home values change, the income of the people who live there, the racial demographic, all of that, right? And that's not by mistake, it's by design, right? So why do we even care about this? The reason why we care about it is because if these neighborhoods, what happens to a neighborhood when people are not able to buy property in that neighborhood? What happens to the neighborhood? So people aren't able to buy property, right? The home values depreciate. They're not able to accumulate wealth. Do businesses want to come to those neighborhoods? No. If businesses don't come, jobs don't come. What happens to the schools? Okay, so Maria's ahead of me, right? Because property taxes go towards funding schools. Exactly. And then thinking back, what are all the social determinants of health, right? Jobs, housing, education, right? So directly, and I'm sure many of you already know that, in many cities, the neighborhoods that were redlined in the 1930s, those are still the same neighborhoods that have the worst health outcomes if they haven't been gentrified. So here in New York City, the neighborhoods with the highest infant mortality rates, with the shortest life expectancy, are those same neighborhoods that were redlined in the 1930s. And so what we do need in order to improve the health of these communities is we need policies for people to have opportunities for home ownership, for people to have opportunities for gainful employment, with sick leave, right, and benefits. We need to improve education in our communities, right? So when we're thinking about how do we strategize to address health inequities, we have to also think outside of healthcare. Okay, we have to think about what policies are going to improve and empower communities, right? How can we center our communities? I'm just going to move forward because I'm running out of time, but I want you just all to think, even on a personal level, right, in your own experience, how has systemic racism, right, some of these policies that I mentioned, and I'm sure they impacted your own families, right? How did they shape opportunities, exposures, and stresses? Okay, I love the chat. Thanks, Brian. Okay, so just based on all of that and the policies I just presented to you, I love this diagram with the escalator analogy. I don't know if people have seen this, but so say on the left side, right, you have a down escalator. What happens if someone's trying to go up the down escalator? What happens to that? to that person. Have you ever tried to go up and, okay, they lose their balance, what else? Can they get to the top? They get tired, they go slow, they stay in the same place or can't move up, exactly. On the right side, you have an escalator going up and a person going up. Does that person have to put much work in? They can make it without even trying, right? But a lot of times people get uncomfortable with the whole privilege thing because they say, oh, I worked hard. Yes, you worked hard, but there was assistance. And so I like to really draw the analogy with those federal policies, right? These policies made it easier for white Americans to be able to purchase homes and to accumulate wealth. And it made it more difficult for people of color too, right? And so when we talk about systems of oppression and privilege, right? We're talking about these policies that advantage one group and disadvantage another group. And then the Sarita says the up allows for white disabled people to go up and access the support they need. Thank you. Thank you for mentioning that. And so I just wanted to share, I don't know if people have heard about the 4 eyes of oppression, but it's just sort of a great way of thinking about systems of oppression and classifying them. And there's actually a great video, YouTube video online. I didn't have time to show you all, but if you Google it on YouTube, there's a 4 eyes of oppression video that really explains it well. But essentially the first eye is ideological, that any oppressive system is based on the idea that one group is better than the other. So this is not just racism, it's sexism, ableism, cissexism, institutional oppressions that are embedded at an institutional level, healthcare, our education system, our political system, interpersonal, which is the oppression I think that we are more able to see very easily because it's usually overt, that takes place between a member of a dominant group and a marginalized group. And then internalized is when a member of the marginalized group often internalize those really damaging beliefs. And so I want to give you just a few examples. So just think about the 4 eyes and just recognize that often multiple eyes are operating at the same time, but there's usually more of a predominant type. So I just want to give you some examples. So I shared this earlier, Black women are 3 to 4 times more likely than white women to die from pregnancy-related complications. Which eye is that? Like, is that ideological, institutional, interpersonal, or internalized? So just drop that in the chat. Right, so that's more, so it's, yes, it's absolutely all of the above, but the outcome is more of an institutional one. Great, thank you. And let me know if the chat box is blocking the screen. Okay, what about this one? The cultural narrative that white patients are more compliant and more likely to follow clinician instructions than Black patients and other patients of color. Is that ideological? Is it institutional? Is it interpersonal or internalized? So good, it's ideological because it's like this idea that one group does things a better way than the other. Ideological, great. What about this one? A Black child identifying a white doll as good and a Black doll as bad. Which eye is that? Good, yes, internalized, good. And then this last one, clinicians are less likely to prescribe pain medication to Black patients than to white patients. Which eye is that? Good, interpersonal, great, great. And so I just want you all to think about the 4 eyes, and we won't have time today, but like thinking about how can we use this framework to envision change within medicine for Black, Indigenous, and people of color, not just patients in their communities, but also clinicians as well, okay? And as I mentioned, I'm happy to send a link to the organizers for the YouTube video, which is amazing. It's very powerful. So just going back, this is like kind of like the take-home slide from the structural competency working group. I want to challenge you all to think further upstream. So on the left side, when thinking about how are we going to address health inequities. And then just some examples from the structural competency working group is of structural competency at work. Is this person, does anyone know who this is on the left side of the screen? This, yes, yeah, right, Dr. Mona Hanna Atisha, who essentially was an advocate for her patients. She noticed that her pediatric patients' blood lead levels were high, and she wrote to her representatives about it. No one responded. So what did she do? She had a press conference, and that's how the world came to know of the Flint, Michigan water crisis. But what was so powerful about it is that she didn't just think about what can I do within the four walls of this clinic or this hospital, but I'm going to be an advocate for my patient, thinking about what structural change needs to happen. Right? Oh, great. Oh, Tanya. Yeah, she sounds amazing. And then the Black Panthers, I always have to amplify their work, right? Because they were thinking about structural competency before it even had a name, right? So 13 free clinics across the country offering free care, food giveaways, free breakfast programs, clinics where they would offer community members legal advice, offering transportation to families to visit loved ones in prison, even performing testing for sickle cell disease, which we know is severely underfunded by the government. And so, yeah, so definitely thinking about how we can all advocate for our patients. And then just to give some context, what does structurally competent care look like in a pandemic? What should healthcare centers do? Healthcare centers should make sure that their patients have broadband access. Yes, they don't necessarily have to provide the access, but they need to connect them with the social services that can help them get access, because how else will they have their telehealth appointments? We should be concerned about our patients' food insecurity and housing insecurity, and ensure that there are services available to help support them. We should, as healthcare professionals, be delivering PPE to community members and thinking about new medical, financial, legal partnerships to help support communities. And so I want to challenge you all just to think about, where are you going to make a difference? I would say that the low-hanging fruit is the individual and interpersonal level. I want you to think about what you can do within your institutions, how you can center communities and engage with communities, because communities often they have the answers. We just need to listen to them. And how will we do research and policy and enact policy that will also make a difference structurally? And so these are my take-home points. So we know based on that racism iceberg, right? It's systemic racism is the risk factor for morbidity and mortality, not race. I want you to think about using the 4 I's and structural competency to think about how do we dismantle racism in medicine. And I want all of you to be inspired to mobilize for health equity. So thank you so much. I don't know if I have any time for questions. I went over a little bit, but thank you so much for engaging in the chat and for your comments.
Thank you so much, Dr. Blackstock. That was such a powerful conversation. I don't know that we have last minute questions. I didn't see any, but
Okay,
I think people have your contact. So
yeah. And I think I saw who sent out the link for the YouTube. I think one of my friends sent it out. Ijeoma, yes, Ijeoma sent it out. Thank you.
Awesome.
It's in the chat for the 4 Eyes of Oppression YouTube.
Thank you. So that was a great end to our day. Matt and Dina are here, and they're going to close out the rest of our conference.
Thank you.
Thank you so much, Dr. Blackstock. That was truly the perfect way to end this incredible day of programming. Matt and I were the co-directors of the executive board of this Diversity in Medicine conference. We just wanted to say a quick thank you for attending the Diversity in Medicine conference today. It truly exceeded all of our expectations. As a medical student group planning our first ever virtual conference, we truly did not realize that this would, 1, work, or 2, be as successful as it is. And we're so incredibly excited about 1, all the incredible speakers that we've been able to learn from, and 2, all the engagement that we've seen. We had over 1,000 people registered to come to this conference and over 200 people at all of the sessions. So we are so excited. Just a few logistical points. Please, if you haven't made a Socio account, do so and check out all the amazing poster presentations on Socio. Those will be available for 30 days after this conference. So please check them out and see the incredible work being done across the country. And we will be working on uploading these videos of these talks to our Socio and to a YouTube channel so that these are accessible after the conference, so we can continue the conversation and continue learning. But like I said at the beginning of the day, we just hope that this conference inspired you. I know I'm so incredibly inspired, and we just hope that the conversation doesn't end here. It's just beginning, and we just continue to take this offline. But Matt, if you could say a few words.
Hi, everyone. My name is Matt Poon, and like Dina said, I'm the other conference co-director and a student here at the University of Michigan. I use the pronouns he, him, his, and I'm an able-bodied cisgender man of Chinese, Peruvian, Polish, and Czech heritage, and I'm wearing a blue jacket and tie with a blue Michigan background. In addition to everyone that Dina mentioned, we also would like to thank our generous sponsors here at the University of Michigan, the Departments of Surgery, Anesthesiology, Urology, Orthopedic Surgery, and Obstetrics and Gynecology. Without their support, we could not put on this event. Thank you also to all of you who have done the fantastic work to make change. Your posters and recordings will continue to be available, as Dina mentioned, and there are so many posters to go through. I haven't gone through them all myself, so we'll make sure that they're all accessible. Thank you also to our faculty advisor, Dr. Okanlami, for his guidance and incredible support in planning this conference and for connecting us to our incredible speakers, panelists, and workshop leaders. And lastly, thank you to the incredible team of students who have contributed over the last year in putting this event together. I'd like to now ask everyone on the team to turn on their cameras so you can see the faces of everyone who made this conference possible today. We hope that everyone had an incredible time today, and we cannot wait to continue these conversations. We look forward to seeing you next year. Thank you.
Great job, team.
Dr. O, you can show your camera too. Turn on your
Yes, you should.
That was awesome, everybody. I don't know if somebody wanted, Maria, if you wanted to take a picture.
Someone should screenshot it.
If anybody's still listening and could fill out the post-conference survey, we would really appreciate it.
Okay, everyone smile. Got it. I'll send it out.
Maria.
Thank you all so much.
Amazing day, everybody.
Seriously, good job, guys. I know we still got 80 people, but you guys rock. That was awesome. I was awesome. So all the engagement in the Socio platform, Q&A, chat, green room, text message, Instagram, Twitter. You guys were managing this from all angles. So really, 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 really well done. That is going to be hard to top next.